Hello and welcome to Unit 2, Part 1, Indications for Sleep Studies, Disadvantages and Limitations. Let's go over the general reasons why people go for sleep studies or their indications and the disadvantages and limitations that come with sleep studies. Sleep studies are either routinely indicated, sometimes indicated, or never indicated for certain disorders or diagnoses. They are regularly scheduled for people with sleep related breathing disorders like sleep apnea and snoring. They can also be scheduled for CPAP titrations, where the technologist experiments with the pressure to find the one that's just right for the patient. Sleep studies can also be used to assess how well a treatment is working, like if a patient is taking Xyrem, which is a highly potent tranquilizer. They have to perform semi-regular sleep studies to prove its efficacy and that the patient is still benefiting from it. CPAP is the same way. CPAP patients are required a sleep study every 5 years to make sure their diagnosis doesn't change or their CPAP prescription doesn't need to change. Sleep studies can also evaluate sleep-related events that are violent or cause physical harm to patients or others, and other certain unusual parasomnias, uh, for instance, sexsomnia, sleep-related eating disorders, or head banging. Instead of routinely, sleep studies are sometimes indicated for patients with neuromuscular disorders with sleep related symptoms. People whose muscles don't work properly, like the respiratory function musculature, while may not be able to breathe properly while asleep. These are patients with ALS or multiple sclerosis, some palsies. Sleep studies may also be scheduled for patients with an arousal disorder or other sleep disruptions that are thought to be from seizure activity. They can be scheduled for a parasomnia or sleep related seizure disorder that does not respond to regular medication for those disorders and needs further evaluation. Sleep studies may also be scheduled if the provider is highly suspicious that the patient is suffering from symptoms of periodic limb movement disorder, PLMD, when people wake up from their leg movements while asleep. A lot of patients don't have arousals when they move their limbs, but PLMD patients do. If a patient is complaining of narcolepsy or idiopathic hypersomnia symptoms, or the physician needs to document EDS, and MSLT can be scheduled. That quote about the guidelines should not be considered inclusive. It refers to the poorly understood nature of narcolepsy and idiopathic hypersomnia and means to say that the guidelines for these procedures are suggestions and not always the only ways or the best ways to qualify a diagnosis for these disorders. For instance, there is genetic testing available for narcolepsy if patients have a very mild sleep apnea case. They may need a study to prove it is causing them excessive daytime sleepiness. Ultimately, though, the clinician has the final say. Providers generally do not schedule sleep studies to diagnose chronic lung disease. However, you can have a sleep study to see how that patient sleeps with a chronic lung disease. For parasomnias that don't cause harm or serious sleep discrepancy, you will not have it's not really indicative for patients who don't complain of sleep problems or don't show symptomology of a sleep disorder. Sleep studies are not used to treat or diagnose restless leg syndrome, nor to establish a diagnosis of depression. Providers can schedule a split night study for patients if the patient has an old or outdated prescription, or if a technologist can modify an NPSG to a split night if the patient has met the qualifying criteria. Typically, the patient must have an AHI of at least 40, must have slept at least 2 hours, must have enough time for at least 3 hours of recorded data on CPAP therapy. AHI, if you're not familiar, apnea-hypopnea index. How many events do you have in an hour, an average? If the patient refuses a split night study, or if the patient is not fixed on CPAP during the first night, a second night titration may be scheduled to really dial in the treatment. Sometimes this takes 3 nights, especially for modes like bilevel and ASV. When first evaluating a prospective sleep patient, a lot of preparation must be done to ensure that they need a sleep study. The Epworth Sleepiness Scale, or ESS, is a popular screening tool to see how easily patients fall asleep in certain scenarios, and is usually one of the first predictors providers will use along with a sleep questionnaire. Sleep questionnaires can be as long or as short as the provider wants, but the questions are usually very detailed and organized by either patient information or sleep disorder. The most common complaints patients admit to are hypersomnia, insomnia, excessive daytime sleepiness, you'll see that as EDS, snoring, gasping, choking, apneas, kicking, movements in sleep, sleepwalking, and restlessness. This evaluation usually happens in the initial sleep visit consultation, where the provider includes a thorough physical examination that details at least the respiratory, nervous, and cardiac assessments. What are some of the issues with having sleep studies? As you can imagine, sleep studies can be difficult for some people. When patients experience either less duration or less quality sleep that they would normally have at home, we would call that the first night effect, which commonly occurs when people sleep somewhere new for the first time. The sleep study process can take a long time to complete, from the first visit to the study to the follow-up and whatever else happens. It's also expensive and takes up a lot of labor. Sleep studies are not helpful in the diagnosis of insomnia or circadian rhythm disorders. Insomnia is usually a symptom of another cause, maybe medicinal or environmental, or due to a sleep disorder or a mental or emotional problem. Sleep studies themselves are not diagnostic tools for circadian rhythm disorders either, although providers will use sleep diaries and actigraphy monitors to help track when the patient sleeps. Not all sleep equipment is made the same, and some software or technologists might underscore limb movements or respiratory problems. It can be easy to miss a quick parasomnia event or seizure activity if you don't know what to look for. Some providers are also split on all the aspects of sleep technology. There are some gray areas which may be open to interpretation. We've covered the basics of these in our presentations on scheduling, but we'll briefly run through these again just to refresh your mind. These are typical sleep studies run in sleep labs: MPSGs, parasomnias, titrations, split night studies, pre-MSLTs, and nocturnal seizure studies. They're all performed during the nighttime. Some daytime studies are performed for special patients, MPSGs, but they would be DPSGs for daytime, PSGs for maybe third shift workers, sleep technologists. Also daytime studies, MWTs and MSLTs. Basic sleep studies last at least 6 hours and are for diagnosing disorders. These are MPSG, where N stands for nocturnal, meaning they take place in the evening. CPAP titrations are much the same, but instead of the nasal pressure sensor and the thermistor, you have the CPAP flow signal in the software. Titrations are for treating obstructive central and complex sleep apnea. A titration must occur after a formal diagnosis is made. It's also performed during the nighttime hours when most patients sleep. A split night can either be scheduled as a split night by the provider, or it could be scheduled as an NPSG in which the patient met the criteria to qualify for CPAP in one night. They can be scheduled as a split by the provider if the patient is predicted to be a severe case or when cost is a concern. For a successful split night, the patient has to have slept at least 2 hours during the diagnostic portion, and the diagnostic portion can't be longer than 3 hours, and you must have at least 3 hours remaining in the study for the titration portion. MSLTs measure the patient's inclination to fall asleep in kind of like a dark room, Diagnostically, MSLTs help a provider rule out or confirm narcolepsy, idiopathic hypersomnia, and it can help verify excessive daytime sleepiness, EDS. MSLTs are usually performed after a verification study to show that the patient can sleep at least 6 hours without having an AHI over 15 and excessive PLMS, or periodic limb movements in sleep, that cause arousals. Lab procedures and policies may vary, and sometimes can vary from study to study as long as the proper documentation is there. I've run MSLTs on people with CPAP before, so they have an AHI, but if it's controlled, they still have narcolepsy. What do you do? There are traditionally 5 nap opportunities once every 2 hours. The naps begin between 90 and 180 minutes after the patient awakens from their nighttime sleep period. If the patient falls asleep during the initial 20 minutes, an additional 15-minute clock is added at the time of sleep onset. Typically, if the patient begins dreaming in the second time period, that is indicative of narcolepsy, especially if 2 of the naps have SOREMs, sleep onset REM periods. If the patient is able to fall asleep and stay asleep quickly, but doesn't dream in any of the naps, that is more indicative of excessive daytime sleepiness or idiopathic hypersomnia. The Maintenance of Wakefulness Test, or MWT, indicates how well a patient can stay awake. The AASM recommended MWT guidelines call for the test to begin between 90 and 180 minutes after the patient wakes from nighttime sleep. That's true for the MSLT as well. Every 2 hours, the patient will sit in a chair in a darkened room for 20 to 40 minutes at a time for 2 to 4 sessions. These are sometimes used for transportation workers, truck drivers who drive at night, who spend their time in a darkened environment for hours on end, not really doing anything other than driving. There is a specific luminosity that is allowed for this test, which is the amount of light in the room. This attention to detail is necessary. This environment should not reflect a place that does. The environment should reflect a place that does not influence the patient to stay awake. There should be no sound, very little light. All that's allowed is like 0.1 to 0.13 lux. And no stimulation. The patient is not allowed to talk, hum, move, fidget, or anything. Just sit there and stay awake. There are a lot of variances between procedures for the MWT, so be sure to stay on top of the procedures in your specific lab. There are some other considerations schedulers need to consider when assigning times for patients. They need to make sure that there is a chronological order to the appointments, starting with the initial consultation, then any testing, the follow-up appointment, or appointments needed in the future. Some labs also have patients just try to take a nap with a CPAP mask as a desensitization measure. Some labs will also provide a desensitization tour, especially for pediatrics patients, to help ease their mind about the sleep study. There are also ad-lib studies, which studies are where the patient is allowed to sleep as long as they want and they can leave when they want. And the priority cases, as far as priority sleep studies or priority scoring, that's strictly up to the protocols of the sleep lab program and how they operate. But some labs have a hierarchy of patients that get the next available study as soon as possible due to several reasons. If they're DMV employees, transportation workers, and people who fall asleep at inappropriate times who are in potentially fatal positions if their sleep is poor. Patients who are losing their health insurance may also try to get earlier appointments to get care before it's no longer covered. Bariatric patients depend on a tight schedule for everything to happen when it needs to in order for them to get their surgery. Some patients with severe consequential sleep apnea, either obstructive or Central may also be assigned an earlier sleep study. Typically, any situation where the health and well-being of the patient or others is compromised can be considered for an earlier study or a priority study. In the presence of certain abnormalities found in sleep studies, you should know when to alert the physician when these instances arise. For instance, any study with questionable EKG or abnormal EEGs those are two good reasons to get the study scored quickly so that decisions can be made in a timely manner. If a patient is coming in for a follow-up, you need the study done before the patient comes back. Split night studies might also be considered a study to score quickly because therapy is usually preempted and they need to get all the information done before it's too late. Because insurance can stop. Insurance is funny. Sometimes if you don't put in certain things, especially for Medicare, within 10 days they won't do it. They won't allow it unless you do it all over again. Kind of silly stuff, but there's a lot of red tape with insurance. So, part 1 is done from Unit 2. Look out for part 2 coming up very soon.